Hello, my name is Bradley Jackson, and I, along with Dr. Abad and Dr. Miller, will be presenting a case series on hypertriglyceridemia-induced pancreatitis, a case series and management approach. Hypertriglyceridemia-induced pancreatitis, or HTGP, accounts for 1 to 14% of acute pancreatitis cases. Risk rises as level of serum triglycerides rise, with progressively increasing risk with levels over 500 milligrams per deciliter. Those with HTGP are generally 10 years younger, male, obese, and diabetic. We present 3 cases of HTGP, all presenting within a 30-day time frame to our hospital. All 3 patients were male, had newly diagnosed diabetes with ages being 28, 40, and 48. Management was tailored to each case depending on etiology, level of triglycerides on presentation, and response to initial therapies. I'll give you a brief overview of the cases and invite you to read them on your own time. The 3 cases involve 3 middle-aged men, all with uncontrolled diabetes with acute pancreatitis caused by hypertriglyceridemia-induced pancreatitis, with other etiologies being ruled out. 2 were considered for workup of familial hypertriglyceridemia, and 1 was purely hypertriglyceridemia secondary to diabetes. Case number 1 was managed more conservatively via standard acute pancreatitis protocol and put on fenofibrate and a statin the following day. He improved quickly before his discharge. Case number 2 had known hypertriglyceridemia, but no previous episodes of pancreatitis, but was non-compliant with medication. He also presented with eruptive xanthomas on presentation with serum triglycerides close to 4,000 on admission. Case 2 and 3 were admitted to the MICU, where IV insulin treatment was started with a target triglyceride level of 500 milligrams per deciliter before transferring to the floor. Of the 3 cases, case 3 had refractory hypertriglyceridemia with chronic recurrent pancreatitis with several readmissions, most likely secondary to medication noncompliance. Now regarding management, here's some details. The cornerstone of management of acute pancreatitis remains true for HTGP as well, beginning with MPO, fluid resuscitation, and symptom control, and also a lipid panel. The importance of NPO shouldn't be neglected or overlooked, as enforced fasting will decrease serum triglycerides rapidly via metabolism of triglyceride-rich chylomicrons. A lipid panel should also be ordered upon initial workup, as triglyceride levels will fall within 72 hours of presentation. A delay can lead to false conclusions about etiology and therefore subject your patients to recurrent episodes. On literature review, it's generally accepted if triglycerides are over 500 but under 1,000, you should begin fenofibrate plus or minus a statin, encourage lifestyle modifications, and practice proper diabetic management. Most data will recommend starting IV insulin therapy if triglycerides are over 1,000, with a goal target of transitioning to oral pharmacotherapy with fenofibrate plus or minus a statin once under 500. Sometimes you will see gemfibrozil used as well. If there are worrisome signs like an Apache score over 8 or multiple organ dysfunction, plasma exchange or apheresis can be considered, and we do have a note here on plasmapheresis here below that you can read. Although effective at acutely lowering triglycerides, heparin is not recommended due to hemorrhage into the pancreas and rebound hypertriglyceridemia. Moving on, first, a brief explanation of the pathophysiology on how does hypertriglyceridemia cause pancreatitis. Triglyceride-rich lipoproteins, like chylomicrons, impede circulatory flow after they embed themselves into capillary beds and then subsequently become exposed to lipase. Subsequent degradation releases pro-inflammatory free fatty acids, causing edema, inflammation, and necrosis. This particular point is important to understand, being that insulin as a therapy, its primary effect on cells is by increasing fatty acid breakdown and reversal of fatty acids from adipocytes, thereby limiting the inflammation, edema, and necrosis of the pancreas. Take-home points are as follows for this case series. Please consider ordering a lipid panel on initial diagnostic workup for acute pancreatitis, especially in areas and populations of increased incidence. Number 2, use serum triglyceride levels to guide your management. If they are over 500 or over 1,000, should be a helpful tool in guiding if this patient qualifies for ICU care. Outpatient screening and treatment for hypertriglyceridemia for those at risk is vital when serum triglycerides are over 500 milligrams per deciliter to avoid HTGP. These cases highlight that this entity is likely underrecognized as a cause for acute pancreatitis. In addition, the literature for HTGP is largely focused on inpatient management, while the literature on prevention and long-term management is sparse. These 3 patients all had known disease or untreated risk factors, which highlights the important role that primary care can play in management of this disease. Thank you.